So we kick off with Feng Xing, who's a consultant geriatrician in US, in Singapore. And his talk is going to be looking at bringing the clocks into clinical practice. I'm also going to do a quick plug for Alice, which is sponsoring this portion of the program, and which we're very fortunate to have Feng Xing on board with as well. So really looking forward to his talk. Feng, thanks.
Okay, thank you, Martin. Good morning, everyone. So my talk will be split into three parts. First part, I'm just going to ease everyone in and introduce you a little bit to Singapore healthcare system. The second part is going to be on clinical aging clocks and how can we, develop them. And the final part is to just showcase what we've been building in Singapore, multiple Singaporean cohorts to validate clocks. Okay, so this is my disclosure. I consult for Alice. So this is Singapore. We're classically described as a tiny red dot on the map, as you can see there. But we've come into the spotlight as being a longevity hotspot and the sixth blue zone, which is, I would like to say, completely engineered. This is Singapore, and Singapore's healthcare system is split into three clusters. I work for the cluster that's on the western side, and that's known as the National University Health System. Under that system, there is hospital-based care, and we have acute hospitals and community hospitals attached to the acute hospitals. And there's also primary care, which is split into a public sector, polyclinics, and also private general practitioners. Apart from that, we have many community health posts, and that forms the community care team, where a bunch of nurses would monitor the residents' health, both in active aging centers, where elderly can attend, and also in their home settings. Okay, so this is the Western region. We cover the health of 1.14 million residents. I work in a hospital located here in a place called Jurong East, and it's called Teng Fong General Hospital. Not that well known, but a relatively new hospital that's been around for the past 10 years. So it's a 700-bed acute hospital with a 100-bed community hospital just attached next to it. And this is me in clinic, and the nurses actually celebrating my birthday. Yeah. Okay, so what have we been doing in Singapore? So there's this program in Singapore for preventive care called Healthier SG. And this program focuses on prevention. So if you're 40 and above, like me, you will get a short message service just after your 40th birthday telling you that you're eligible for this program. When you sign up for this program, you get a dedicated family doctor, you can have a personalized health plan. It's heavily subsidized in terms of screening, also vaccinations. The doctor can, prescribe some lifestyle modifications for you, and you can access to community support, for instance, nursing support in the community or physiotherapy, occupational therapy needs, depending on what your exact needs are. But the question is, can we do better? So this is an article I pulled out from the local newspaper, the Straits Times, and this is our health minister, Mr. Ong Ye Kong, and he says here that we want to use AI to help doctors predict disease risk in the next phase of Healthier SG. This is an excerpt from the article, and you can see the highlighted portions. And the focus in Singapore will be on AI, aging, and healthy longevity for the next few years to come. So what are we exactly doing in Singapore? So I am plugged in to all three arms, and here we have a so-called precision general medicine team. We have the cohort arm, clocks and resilient markers, and interventions. And if some familiar faces there you will definitely see. So Jan gave his talk yesterday, which is titled From Theory to Practice. And if you notice, the title of my talk today is From Cohorts to Clinics. So in terms of cohorts, I work with Professor Koh Boon Pui. Here, we have multiple Singaporean cohorts, and we're one of the largest cohorts in Singapore. The Singapore Chinese Health Study that's been around since 1993. We have 63,000 participants. We have blood bank samples for these people, for 32,000 of them from the year 2000, and we're following them up longitudinally with outcome measures subsequently. Apart from that, we also have the lifelong study, which if I have time, I'll delve a little bit into that. That's an AI platform where we have access to 10 million patient records from the past 20 years and active 1.14 million patient records, which we are looking at clock deployment and validation. I will focus a little bit later on the CogAge study, and of course we collaborate internationally and we have access to publicly available biobank and names as well. Okay, so this brings me to the next part of my talk. What should aging clocks deliver? Quick recap from Jan's talk yesterday. How can we measure biological age? You have a biological feature space, you have mortality data, apply a mathematical ML or AI tool, and then you want to predict mortality, health, biological age. Okay, so quite a number of points, but I want to focus first on individual prognostication of clocks, and clocks should help us to predict future disease and health status. Okay, again, a recap from yesterday. For those who might have missed Jan's talk, we have a working clinical aging clock. The updated model is called Lineage 2. It predicts biological age. Essentially, we take demographic, questionnaire, exam, and clinical laboratory data with mortality data, apply principal component analysis, a form of dimensionally reduction, do Cox proportional hazards modeling with the PCs that's sex-specific. 17 of them are separately for male and females. And here you can see the scatter plot on top, separately for male and females for chronological age versus biological age, and below are the survival curves for a particular age bin. So Lineage 2 and Lineage predicts mortality better than clinical risk scores. So of course, why that's not really surprising. So if you see here, these are receiver operating curves in terms of different mortality, all-cause mortality, cardiovascular disease mortality, non-cardiovascular disease mortality, and cancer mortality. You can see that clinical aging clocks outperform the atherosclerotic disease ASCVD score, which is some of you may know as a Framingham Heart score, and also outperforms the clinical frailty scale. And also, as Jan had showed yesterday, we perform as well, or even better, than some mutilation clocks. All you need for this clock are 60 parameters. Why did we choose this? Because in Singapore, as I mentioned earlier, we have screening programs. GPs perform a panel of bloods for our patients, and these are the commonly available or performed bloods for screening panels. So all we need are 3 tubes of blood, 1 urine sample, some of your medical history, physical parameters, and we can predict your biological age. So Lineage 2 also predicts health span, as you can see here, cognitive scores, gait speed, and ability to work, IADLs or instrumental activities of daily living, and basic activities of daily living. You can see that the clock can pick up those who have poor ability to work, can't perform all their ADLs, poorer cognitive scores, and poorer gait speed, and these people have a higher delta age. Okay, but that's fine and well. People build clocks, do it in many cohorts, but what does it mean? How can we make them actionable? So this is a small study that I have in my clinic called CogAge. It's a prospective cohort pilot study. 71 participants, 22 males, 49 females, 65 to 95 years old. I recruited most of them from my clinics and from my fellow geriatrician clinics. We recruited them from January 2024 to March 2025, and we have 30 years for outcome tracking. Okay, so similarly, you see here that the Lineage 2 trained and tested in NANES applies also to our Singaporean older adults. And you can see here, again, a similar scatter plot where people could be biologically older or younger, and that Lineage 2 tracks with dementia status, low hand grip strength, and slow gait speed as defined clinically. So low hand grip strength as defined by the AWGS guidelines, less than 28 for men and less than 18 for women in terms of kg, and the gait speed of less than 1 meter per second. This is all in older adults, so you can see the age gap or the delta age for that being higher for people who have dementia, low hand grip strength, and slow gait speed. Yeah, but this is all fine and well, right? Because this is what we usually publish in our papers. We show aggregated statistics. But I want to focus on individual cases today. And this is going to be the exciting part I'm going to talk about today. I'm going to showcase 4 cases from the cohort, and we'll go through them. For the medics here and the physicians, you'll be very familiar with this because this is how we talk at all our medical conferences. So I bring you to case 1. This is an 85-year-old Chinese lady, no known drug allergies, non-smoker, non-drinker, did not complete primary school education. Her instrumental activities of daily living are generally assisted dependent, but she's still independent in shopping, cooking, and also using the telephone. Her basic activities of daily living are independent, so ability to self-care is good. She could walk without a walking aid. In terms of her past medical history, she has hypertension, hyperlipidemia, gout, previous stroke, mild Alzheimer's disease with cerebrovascular disease, chronic kidney disease, primary biliary cirrhosis, Hashimoto's, thyroiditis, anemia of chronic disease, degenerative spine disease, osteoporosis, and previous hip fracture. So she's got multi-morbidity. She came with her daughter, usually, walked into my clinic. We did lineage 2 for her. The chronological age was 85.6. Lineage 2, biological age was 119.6. Biological age delta was plus 34. She passed away from stroke 4 months after lineage 2 was measured. Okay, but does it only pick up people who are unwell? Second case, different person, 80-year-old Chinese gentleman, again, no known drug allergies, non-smoker, non-drinker, completed secondary school education. All his ADLs were independent. He could walk without a walking aid, had hypertension, hyperlipidemia, atrial fibrillation with a relatively high stroke score, a CHEST-VAS score of 5, had previous stroke, degenerative spine disease, and history of falls, so actually a recurrent faller. Chronologically was 80, lineage 2 biological age was 69, his delta bio age was minus 11. No adverse outcomes to date. Interestingly, lineage 2 contains some nutrition parameters like the B12, folate. These were low for him. And we would not have detected that had we not done lineage 2 because these markers are not commonly measured unless you're cognitively impaired. Okay, so then what should existing clocks deliver? It should identify existing disease, right? Because we have clinical markers we understand well as medics, as clinicians, and when we do these tests, when we know they're low, we can replace them or we can intervene. So this is a slide that I think Jan showed yesterday too, but this is a problem with some of the clocks that we worry about, that potentially could the clinical aging clocks or any other clock actually conflate biological age, so give you a biological age of 200, for instance. But here, lineage 2 does not lead to excessively high estimates of biological age in disease subjects in NHANES, and the biological age and age delta never exceeded 105 years and 35 years, even in very sick patients or participants in NHANES, as you can see here below, for heart failure, cancer, and people on dialysis. Okay, this is a heavy slide. The point to make here is that, look, 71 participants did lineage 2 in my clinics. 20 people had low B12, 5 had low folate, 2 had iron deficiency, 1 had iron deficiency anemia, so on and so forth. All these people had replacements for their nutritional deficiencies or appropriate referrals for iron deficiency anemia or for macroalbuminuria, which could lead on to chronic kidney disease. But one subject had very high CRP, 122. So why? Okay, this brings me to case 3. It's an 86-year-old Chinese lady, no known drug allergies, non-smoker, non-drinker, did not complete primary school education. All her IADLs were dependent. Her BADLs, or in terms of ability to self-care, were independent. She could walk without walking aid, very poorly controlled diabetes, hypertension, hyperlipidemia, mild Alzheimer's disease, osteoporosis, and diabetic retinopathy. So she had a high CRP and I was wondering where that was coming from. So I took a history from her. No upper respiratory tract infection, urinary tract infection, or gastroenteritis symptoms. No fever, but she has been persistently scratching her scalp. Her daughter accompanied her, said, can't get mom to stop. She's been seen by 2 GPs, had the scalp treated with topicals, not better, and she's supposed to be losing weight. So on examination, she was afebrile, did not have a fever, blood pressure and heart rate were relatively normal, little on the higher side in terms of the heart rate. BMI was okay. She was comfortable and non-toxic. And this was how her scalp looked like. In fact, these are pictures I pulled off from the internet, but her scalp looked worse than this. angry, erythematous, nodular, lesions, and scaly, and she had been scratching away. So my diagnosis initially was scalp folliculitis, but I needed to urgently rule out scalp squamous cell carcinoma, so I made an urgent referral to dermatology. She was seen by the dermatologist, diagnosed with scalp folliculitis, treated with oral doxycycline. Of course, she had lineage 2 done. Chronological age was 86. Biological age was 101.5. Delta bio age was plus 15.5. But the question is, so she's unwell, right? CRP could go up. Clinicians will know that. But is CRP driving up her biological age to be higher than expected? Okay, so here you can see, and this is a little bit complicated, but these are actually PC bar plots. On the y-axis, you can see the PC values, and on the x-axis are the different PCs. So as I mentioned earlier, we have sex-specific PCs. These are PC1F, 2F, and so on and so forth. You can see PC1 is plus 30.04, and the rest of the PCs do not contribute much. So you think, okay, what's going on? You can interrogate this further, a little bit deep here, but you can see on the right side are the clinical parameters all over here with the values that she had for each test. And the heat map, in terms of the red color, refers to the age contribution of each parameter overall to the PC and to the delta bio age. So if you focus on PC1 alone, you'll see that, hey, look, interestingly, it's blue. It's not red. In fact, it's red on PC39F, which is over here. It doesn't contribute much to the delta bio age. So if it's blue, doesn't contribute much to delta bio age, then why is the PC1 high and where's this high CRP and why is this the case? Okay, so this brings me to my next point. What should clocks do? We should be able to detect early, hidden, and subclinical disease, and the clock should be interpretable and also explainable. So Jan may have showed this yesterday, but PCs can be interpreted. This is actually taken from my MPJ aging paper, where we looked at associations of each PC with different disease or lifestyle factors. And you can see that PC1, here, I highlighted fibrinogen because it's an inflammatory marker, that PC1 is cardiometabolic inflammation. Okay, but then people ask, sure, you build a clock in a group of American people from 1999 to 2002, but then you're applying it to a group of Singaporeans who are completely different in terms of ethnicity, diet, lifestyle, so on and so forth. And when we did PCA for this particular cohort, CogAge, SEN1 patients, we compared PC1 between CogAge and Enhance, you can see that the PC1 loadings are actually conserved. So there is a conservation of biology between people from very different time periods and also from people who are vastly different in terms of ethnicity. Okay, so back to case 3. So case 3 had high PC1 not explained by CRP, so why is PC1 high? Okay, you can see here, these are the contributing factors to high PC1, and some of these things medics will be very familiar with. High systolic blood pressure, high glycohemoglobin, high blood urea nitrogen, high glucose, high creatinine, high urine to albumin creatine ratio. Obviously no surprise, right? She had chronic kidney disease, she had poorly controlled diabetes, so some of these markers are intuitive. So PC1 is driven by poorly controlled diabetes, hypertension, kidney impairment. Okay, this is another way to visualize the PC, and this is all in the MPJ aging paper and the supplementary methods. If you're interested, you can go look up the paper, it's all there. PC1, and these, so just to explain a little bit about this, basically what we did was we did the disease associations for people who had high PC1 in an American cohort. So for these particular people who had high PC1F, it's associated with hypertension, hypercholesterolemia, so on and so forth, cardiometabolic disease, which this lady had. And we suggested a bunch of potential interventions you could do based on the high PC. Okay, so but PC1 also predicts dementia in the CogAge cohort. And here you can see the box plots for PC1 that it's high in people who have dementia versus no dementia. And of course, going back to the table again, you can see that people who had high PC1F or M in Haynes had causes of death related to Alzheimer's disease, both proximal causes within the next 0 to 5 years, and also more distal causes within the next 10 to 20 years. Okay, but what we also did was to use logistic regression to see whether we could use PC1 to predict dementia. And interestingly, PC1 significantly predicted dementia status even after adjusting for chronological age. As an interesting observation, for case 3, her dementia progressed 11 months after lineage 2 was measured. Okay, back to case 1. So case 1 passed away from stroke, as I mentioned, right? So CCOD is certified cause of death. So back here, we can see her PC1, sorry, go back again, plus 35.5. If we look at the table, early causes of death within 0 to 5 years, stroke. Okay, when we ask as clinicians, what could we have done better clinically? These are her heat maps for case 1. You can see here, she had high systolic blood pressure, 180, low hemoglobin because she had anemia of chronic disease, but had not had endoscopy evaluations done, had high uric acid because of gout, had kidney disease. Of course, we could do all these things. We could have given her angiotensin receptor blocker to bring down the BP that would help the albuminuria. We could have used antiplatelet therapy like aspirin, but to proceed with caution because of anemia. We could give allopurinol for uric acid. We give her a statin to bring her LDL. But it was tough because she had primary biliary cirrhosis. So I did try to give her a statin, but her AST and ALT went up subsequently, so I had to stop it. But will it really help? These parameters take time to lower. This is risk reduction. And so my guess, probably not. Maybe we have pushed back the lifespan by a few months, not significantly. So we should be early and proactive and to start treating risk factors early. Okay, case 4. It's not just PC1. So 82-year-old Chinese gentleman, no known drug allergies, non-smoker, non-drinker, did not complete secondary school. His instrumental activities of daily living are assisted to dependent. His ability to self-care is independent, could walk without aid. Hypertension, hyperlipidemia, atrial fibrillation, mild Alzheimer's disease with cerebrovascular disease, pseudogout, degenerative spine disease, and osteopenia. These are his PC plots and heat maps. You can see that PC1 is 10.5, but PC16M, 31M are high. So if you look at the heat map over here, NT-proBNP, which is a marker of cardiac function, self-reported health, and urine albumin to creatinine ratio is slightly high, but okay, can't really make sense of it. What am I going to do with a high NT-proBNP? But you can look at this using the tables, as I've mentioned earlier, and you can see that potential early causes of death include stroke, there's vascular aging involved, and as an observation, he was admitted for a transient ischemic attack 9 months after lineage 2 was measured. So transient ischemic attack, for those who are not aware here, is kind of like a minor stroke, but you do make a full recovery. Okay, that brings me to my next point. What else should aging clocks deliver? We should be able to personalize intervention targeting and quantify individual risk and benefit, just as what Jan said yesterday. So this you can get from the paper, NPJ Aging. This is actually 2 separate Haynes participants, both chronologically 72 years old. The one above is a moderate smoker, high BMI, died at 77.4, cause of death was diabetes. Gentleman below, non-smoker, good BMI, died at 91. Well, you could postulate that if you had treated this chap potentially with a GLP-1 receptor agonist to control the obesity and the cardiometabolic risk factors, perhaps he could end up like this gentleman, died at 91 instead. Going back to case 2, I like to say we all want to be like him. So why? So he had a negative delta H of -11, but could we do better? So here, if you look at PC17M, it's slightly high. If you look at the heat map, you will notice that B12 is low. It gets a white color, which here it's about a 0.13 contribution to the H delta. If we gave him B12 replacement, potentially, yeah, maybe we could lower PC17 and improve his delta bio-H. But unfortunately, at this moment, it's cross-sectional data. We don't actually have a repeat of lineage 2 for these people yet. But then, of course, let's not forget PC1, because it's also high. And so what can we do about that? Going back to the table again, you can see both PC1M and PC17M associated with hypertension. So his BP is slightly high. Losartan seems a reasonable choice, right? Because we have some data from ITP in male mice that losartan may actually improve health span and lifespan. Okay, to my last point, before I move on to cohorts, it should allow us to track intervention efficacy. And this is from the first paper published in Nature Aging. We analyzed the calorie data set, and that people who had mild calorie restriction had significantly lower biological age. Okay, so this is a summary slide on what should aging clocks deliver, should identify existing disease, should enable us to detect early hidden and subclinical disease, enable individual prognostication, enable personalized intervention targeting, and enable us to track intervention efficacy. Okay, what's next? So I'm going to talk about the Singapore Chinese Health Study I mentioned earlier, one of the largest population-based cohorts on which I'm the co-PI and future PI of this cohort. Started in 1993, 60,000 participants. The initial purpose of this cohort was actually funded by NIH. And the idea was to look at genetic and lifestyle factors and to look at cancer risk in Chinese Singaporean. But the cohort is evolved over the years. You can see here, we started 63,000 people. 32,000 gave us blood in the year 2000-2004. We just finished our follow-up of 5,000 subjects aged 68 to 100 in follow-up 6. We have a nested SG70 study, 1,500 subjects aged 68 to 80. So what is SG70? SG70 aims to phenotype these people in terms of multidimensional frailty, look at multi-system phenotyping, and also multi-organ health, and we have aging outcomes for these people. So bear in mind, these 1,500 people also have blood samples done for them in the year 2000 to 2004. This is center visit 1. We did neurocognitive assessments for all 7 cognitive domains for them, physical measures, vision, spirometry, blood and urine collection, stool collection, oral health examination. This is visit 2. We did MRI for all of them. We have skin physiology findings. We have hearing assessments and audiometry for all of them. This is visit 3. We have 2D echocardiograms. We have also ABI and TBI, which is vascular assessments for these people. And visit 4, we have DEXA scan, fibroscan for the liver. And we have stored plasma, serum, DNA, urine, mouthwash, saliva, stool for all these participants. And these are all the imaging data that we have for them, including aura ring data. Okay, but what's next? So I've mentioned here, we have just completed SG70. We're going to do a cross-sectional validation of lineage 2 in these 1,000 people. We're going to do deep interpretation of PCs because we're able to now. We will have outcome measures for them. We are going out for the second phase of SG70, called SG70 at home. So we're going after 2,300 older adults in their homes, 2 visits. First visit, questionnaire. Second visit, physical measures. And also taking their blood and urine samples at home. We'll repeat cross-sectional validation of lineage 2 and do deep phenotyping of frailty for these people. with follow-up outcome measures. This is my last slide. And this is what we have in Singapore in the National University Health System called Endeavour AI or Discovery AI platform, where we can mine the data set for 10 million people from the past 20 years with mortality data attached nationally. And we have active access to 1.14 million residents' medical records. Ideas to build cohorts within Discovery AI, validate them, and deploy them in EPIC. So EPIC is, for clinicians who may know, this is essentially the electromedical records that clinicians use for a day-to-day basis. So we're currently exploring 2,800 patients who had undergone elective total knee replacement. And this is me in the data visualization in the map. And some of you may know that's actually Jakim sitting over there, our data scientist. And that's all I have. And so thank you, everyone, for this wonderful journey for the past 3 years. I'm happy to take questions.
Great talk. Thanks very much. So you have presumably longitudinal records for many of these people going back 10, 15, 20 years?
28 years.
28 years. So what's striking is you're catching people as snapshots late in life. Can you actually deduce from those medical records what should have been done and when it should have been done, so that they arrive with a positive biological age difference rather than the negative biological age difference? Can you impute that?
You're referring to, I just want to clarify that question. Which cohort are you referring to?
Any cohort.
Okay.
So, I mean, right. I'm looking at your cases and saying, what should have happened when, so that they were not in that state when they were 82?
Okay, good question. So if you're talking about the pilot cohort, probably not. But for Singapore Chinese Health Study, they were recruited between the ages of 43 to 55, 28 years ago. We have blood samples from them. So one of the ideas would be look at longitudinal clocks for this particular group of people. So watch out for this space. We have the ability to do things like proteomic clocks longitudinally in our cohort.
Thank you very, very much.